I'm here with my good friend Susan Jacob. Susan, you know, I interview people all the time, and I'm happy if I can learn one or two new pearls. With you, every time that we speak, there's a whole new surgery that I learn, and that's exactly the case today. You spoke about air pump assisted PDEC. Now we're going to look at some beautiful video that you brought, but before we look at the video, can you just tell me, just grossly, what the procedure is?
Yeah, sure. Josh, first, thanks for inviting me here. It's always great to be here with you. Air pump assisted PDEC is something that I had started, I've been doing for quite some time now, but I've kind of now started to talk about it more. And what it basically does is, you know that DMEC surgery and PDEC surgery is quite difficult. The uptake by doctors is difficult, mostly because it's a more difficult graft to handle once it's within the anterior chamber. It doesn't always obey you, it just moves around randomly and things like that. So when Dr. Amar started PDEC, pre-Descemet's endothelial keratoplasty, one of the advantages that we found with the graft was that you could use very young grafts, number one. And second, the graft had a certain robustness to it or a certain strength to it which prevented it from tearing. So these were two big advantages. And one of the disadvantages that came along was the younger grafts tend to sprawl up more. And also in DMEC this often happens, you know, you use grafts and the older grafts are the ones that open up nicely, and that's why they say the beginners should start with older grafts. And the younger grafts tend to sprawl up tightly. So this is one of the problems that many doctors do face when you're trying to start out with PDEC or DMEC. Now the disadvantage of taking an older graft is of course obvious, you know, you have less endothelial cell count to start with, so you would like to go in for younger grafts. Now air pump assisted PDEC helps you in doing a lot of procedures or intraocular maneuvers within the anterior chamber and helps to make the whole surgery simpler. So I think it'll probably be easier if I can show it on the video.
Oh, absolutely. Let's go to that beautiful video now.
All right, Josh, so you can see that this was a patient who had the ICE syndrome. He's got peripheral anterior synechia all over in the periphery. And I've already removed the cataract. I've put in an intraocular lens. And now I'm going to first release the peripheral anterior synechia because I don't want them there after having put the graft in. They can cause possible graft detachment. They don't give you enough space. And you can see what I've done is I've got continuously air going into the anterior chamber through a needle, and that's the reason I call it air pump assisted PDEC. It gives you that tamponading of the bleeding that could have otherwise possibly happened and makes the surgery much more clearer. You don't have that blood left behind in the anterior chamber. You don't have it going into places where you don't like it. You don't have clots in the anterior chamber. And also blood in the anterior chamber can lead often to a fibrinous reaction the next day, which also you want to avoid. So I will now start using the anterior chamber maintainer for air pump assisted PDEC. Now this is a trocar anterior chamber maintainer. This is one of the ways that you can do it, and this was started by Dr. Amar Agarwal. But the other way to do it, if you don't have the trocar anterior chamber maintainer, is just to use a simple anterior chamber maintainer. You just make a paracentesis and use it. So what you can see I'm doing is now I've marked the cornea, and the first advantage or the second advantage of the air pump assisted PDEC technique is that you go ahead and you do your descemetorexis under air. So there's constant, the reason I called it air pump assisted PDEC is very simple. It's just an air pump that's continuously pushing in air into the anterior chamber, and you can see what that does is it lets you do a descemetorexis just like you would do a capsulorexis. You know, it's kept the descemets against the cornea, and it gives you clear margins, visible margins of the descemetorexis, and much like a capsulorexis you can tear it around easily. It doesn't flap around in the anterior chamber as it would have otherwise done. The second important step now is to do a peripheral iridectomy, and this is again important because it allows you to do this without bleeding in the anterior chamber. So any intraocular maneuver, for example, when you're coming in, and many of these patients have a lot of peripheral neovascularization, and sometimes blood seeps into the anterior chamber through that, but when you have this continuous air insufflation going, it prevents all that kind of blood going into the anterior chamber. This is another technique of mine which I call as EDMEC, or endoilluminator ester DMEC, and I think we've talked about this in one of our previous shows. And what this does is it basically allows you to identify the side of the endothelium very well. The endothelium always curves is on the lower side, and the descemets is what curls upwards. So you can see with the E-PDEC, when it's translated to PDEC, you can easily find out the orientation and you can unfold the graft. Now note at this time that there's no saline, there's no air going into the anterior chamber. It's just plain the BSS that was there in the anterior chamber. For now, you have switched your air pump off. Now you go ahead, you open up the graft and you float it up. Now what happens, as I said earlier, in the younger grafts or in many DMEC grafts is that you're able to unfold it to a large extent, but sometimes those very extreme peripheral edge folds create trouble for you. You may not be able to unfold it all the way, especially if you're working with a younger donor. So what you can do is once you have unfolded it to quite a large extent, you can put in that air bubble, and you can see now I again go in with my technique of air pump assisted PDEC, and I've got air starting to flow into the anterior chamber again. If you look carefully, you can see that small little bit of a fold, which will come now in the video again. There's a small little bit of fold on the left hand side, and I'm unrolling that by going into a plane between the descemetes or the Duas layer and the stroma. And the advantage that this does is the air is holding it up like a third hand within the anterior chamber. It's preventing it from falling down. Every time otherwise, if this was not there, every time I entered and exited the eye, the anterior chamber would have shallowed, the graft would have dropped down, and this would have been a mess, But the air continuously supports it. You can center the graft, you can unwrinkle the graft, you can have the air going till you're finishing your suturing, and that continuous air pressure, which is pushing the graft against the overlying stroma, helps to give you better adherence of the graft even post-operatively. So you can see that though I started out like that, now it's a beautifully centered graft. This is a post-operative first day appearance, very clear. Of course, you need to make sure that you don't handle the graft too much. Your touch when you're doing with the air pump assisted technique should be only in the periphery of the graft, as minimal touch as possible. But you'll see that little bit of touch, even though you do, it makes it worthwhile to not have done much more maneuvers which you might have ended up doing without this technique. This is the 4-week post-operative appearance of the same patient, and you can see he's got a very clear cornea, and he was at 6/6 vision, now 20 by 20.
Susan, that's brilliant stuff. First of all, it's a wonderful video, but I can see the advantage to doing this because not only are you maintaining air there, but you're maintaining this sort of pressure head with the air, and that you don't have to worry about air burping out when you're going in and out of wounds. Is the technique hard to learn?
Actually, no, it's very, very simple. In our hospital, we've been using gas-forced infusion for phacoemulsification for many, many years now. And what we often do is just buy $1 fish aquarium, the air pump, and connect it.
Really?
I know you may not be able to do that here. But you do have a lot of phaco machines now with the pressurized air infusion system. They're vitrectomy machines, so it can easily be translated. You just have to connect it to one of those systems and have air infusing continuously. That's what we also do now. And the good part about it is there you can actually adjust. You can put it up to 50 millimeters if you want, or you can bring it down when you feel you want it a little lower, and things like that. The advantages, as you said, is it prevents the air from collapsing. It prevents the air from coming out, the anterior chamber from collapsing, and it keeps holding that graft up. It doesn't allow that graft to drop down at all, so that all your other maneuvers are very clear, crisp maneuvers, and you can just do what you want, exactly where you want, and come out.
And it doesn't look like, look, you make everything look easy, but it doesn't look like it would add much time to the case.
No, it doesn't. It actually decreases your time because you're not spending all that much of time, doing other manipulations which would have actually involved, moving the graft around, trying to center it, hours and hours doing all this, when you can actually just do this. There's generally that very small edge fold which you need to remove, and that's generally easy once the air is going on.
Susan, this is brilliant stuff. I'm delighted that you brought it. And that we had a chance to speak about it. I want to thank you very much for your generosity with your time with us today.
Thank you. Always a pleasure, Josh.